Hello, how's everybody doing? This is totally, I'm having like original pharmacy flashbacks. Like when I started practicing, we always stood on that like all high platform above everybody else, where people would come in and say, I would like drug advice, and I'd be like, I will give you advice from on high. Something else you'll notice is my lovely blue screen, which I found out today is not good for anybody who has brain injuries, so I apologize. We could change it to a brown hue, I guess, which would be better anyways. Yeah, I'm a pharmacist. We kind of do things on the fly. Doctors are really prepared and smart, and after listening to all these speakers today, I'm kind of intimidated, so I'm just your local pharmacist. I've been practicing in Windsor, Essex County for, like, say, 20 years. I've practiced in the States, in hospital, and retail. I was asked today to talk about drugs, but then, like, the third speaker today basically covered all the drugs. So I'm like, oh, wow, what am I going to do now? I kind of like to go on the fly. It's really kind of, I'm trying to give you guys a perspective from a pharmacist. Like, I was talking to somebody earlier, and we're a very unique profession in the sense that one thing that sets us apart from other health practitioners, I always say we're the only health practitioner with a cash register. And what I mean by that is, you know, you see your doctor, you leave, you see your dentist, you leave, but in a pharmacy, your last interaction with us is you're going to give you money. So it changes perspectives of people that are coming with us. So they do see us as a healthcare practitioner, they also see us as, you know, somewhere I can buy milk. So it's depressing. And from a nutrition standpoint, my favorite advice is when I hand out cholesterol medications and the person looks at me and goes, so chips are on sale. And I'm like, yes sir, yes they are. This is good life choices. So it kind of changes, and actually over COVID for the last couple of years is one of the things I advocated for. It's really changed. People are getting more injections from us. We're starting to do minor ailments, so a lot of different things that are changing. So now from a perspective of a brain injury, the problem for myself is, and I admire all these other people talking, I'm so dealing with these issues on a downstream level. And what I mean by that is, by the time a patient has come to me, they've already had the injury, they've already been assessed, they've already seen multiple physicians. Those physicians have all made choices on what they're going to do for medications, and they never disagree with each other, ever. They always all get along. And then they show up at my door and go, here. And then I always say, so the doctor told you what this is for? They always say yes. They're usually like, no, I don't know what I'm having this for. You're like, well, what happened? They're like, I don't know, that's some sort of accident. So then, I basically, it's like escape rooms. You basically just have to pick little questions out to figure out what's going on here. And then on top of it, so now we get the medications which we think are the best. We're not quite sure, and so we're going to try. And I don't know how it's going to work. I've got a book and years of studying to say, I think this is what's going to go. And then everybody's different. So what will work for you will be the exactly worst thing for her. And then on top of it, then we have side effects. And then, you know the easiest way to treat a side effect? We should just give more meds. And then there's another side effect. You know what we can do then? Bingo, we're going to be at 3 minutes. And the biggest, and then the other issue too, like I said, is my biggest complaint. So if I'm talking about anybody for brain injury is like, we're not treating the cause, we're there to treat symptoms. So it's I have to lean on the optometrist to say, this is what the issue is, this is the drug I'm going to choose, and obviously I think that's a good choice. And we're going to go at it that way. But like I say, we're trying to minimize everything that's going on. I'm all over the place and I get distracted. Comedy's way easier than pharmacy. Anyways, sorry, it's been a really long day. I can't come up with funny things all day and actually talk at the end of the day. It's not fair. But you know, what I want to do is, like, there's a couple things. What I hope that all of you do and all the patients that you're interacting, or if you are a patient, I need you to be an active participant in your care. Far too often I have patients that come in who are just passive. Why did the doctor prescribe this? I don't know. What are you taking? I don't know. How's it working for you? I don't know. So you need to necessarily encourage any of the patients that you're dealing with, or if you are, to be empowered to ask questions. It's such a scary thing. The amount of times I hear patients saying, well, what'd you do it for? I don't know. Why didn't you tell me? The doctor scares me. And I don't think the physicians that are out there, I don't know if you realize how high of a platform patients put you on. You are, in essence, the word of God coming down. I am in a very traumatic experience. Something has happened to me which I don't like. I have been directed towards you, and you are the optometrist god, and you have to fix this. And then you put weird glasses on my eyes, and I'm like, what's going on? So you've got to really realize, we've got to advocate for it, and far too often, so it's a matter of sitting down. The same point is I always tell, you know, the big pharmacy joke is when people call sale a refill, and they say, what pill? And they say, white round one. Oh, the white round one, that would be helpful. The other aspect, so if anybody's got any, does anybody have any preset questions? I know I was talking to people earlier, but you do. Look how fast that handled it. Okay, I was going to say something else. But go ahead, what's your question there?
Do you find people who are on medications prior to the accident, and then they stay on those medications and the head traumas happen, they're not having the same outcome of pre-existing prior prescribed meds? So your role when they talk to you about it doesn't seem to work the same?
So the question is I have patients who are on a certain medication regime, something happens, a head trauma happens, and when they come back, do the effects of the medication change? Yes. And it's a really simplistic. We are a giant bag of chemical reactions. So you run this bag of chemical reactions here, I get into an accident, massive trauma on the brain, which is usually I like to simplify things because I'm a simple guy. So then, you know, you're changing the basic chemistry of the body, and then you're going to expect it. So a lot of things do change. So it's a matter of trying to discuss, and yet again, patients are leery. You're going to find as patients age, very leery of changing anything. Because if you get anybody over probably 70, actually probably 80 now, because they started practicing 20 years ago. Any people the value, because they know there's a value to the medication. And they're like, well, I gave it to you, I have to take it. So what I want, my favorite thing is when we get, one of the advice that I tell a lot of people to do, sorry, I'm broadening off this question, but any patients that are on, especially with brain injury, really encourage them to do compliance packaging, where the pharmacies will actually package. And here's the scariest part, and I'm telling you, you'll get a patient to compliance pack all their meds. So we'll have them come in, they'll bring all their medications in, we will then package them in a nice package, and it's really simple. There's 4 weeks of meds. Then you've got 4 weeks of meds. And you'll do that for several weeks or several months. And then on month 3, you'll go to deliver their meds, and you know what they'll tell you? Oh, you don't have to deliver it to me. I said, why? So I got lots. And so you're like, do you ever forget to take your meds? Oh, no, I take them all the time. All the time? All the time. Never miss? Never miss once. I'm like, but you have 3 more weeks. Yep. Okay, so we also make these assumptions that once we give great advice to patients that they're going to follow it. So, but anyways, yeah, always doing adjustments for all the time. It's going to happen at all times, and you really have to. And I'm talking about everything, like going back to, and that's the other part. The one thing we do poorly in medical is we don't de-prescribe. So I have a patient, a patient would come in with a brain trauma at an older age. I mean, he's on cholesterol med. Listen, cholesterol meds are really important. It's great, and if you have a family history. But at this point, is really cholesterol my big concern? It's just that, or you prescribed something years ago and they just basically keep staying on, Is there any other questions? I know Melanie had a question about CBD, which everybody wants to know about. She's smoking pot, but don't tell anybody. Any other questions on that?
Actually,
Yes.
I had a question about what you call compliance packaging.
Yes.
I would call like blister packs, right?
Well, you could okay.
Well, or whatever.
Tomato.
Right. So, when we talk to patients, compliance package sounds like forces coming in.
Well, they are.
So how do you shift patients from having their bottles
And
getting to packaging it?
And that's a real, and it's women handle it better than men. Older patients do. I equate blister packing or compliance packing of meds as taking someone's license away. So as soon as I tell a patient, I want to put your pills in either compliance pack or blister, they're called blister packs because most of you just punch them out, so they've got little blisters. It really feels, why are you taking my med? I'm smart, I know what I'm doing. I never miss my medications, I never take it. So what I usually do, the best time to probably get someone to switch over is at the instance of issue. So like when there has been an accident or some massive dose has changed. And then my best verbiage usually is to say, listen, you have got so much going on right now with all the other things, all your appointments, all the other stuff that's going on. Do we really want to add another facet of medication? I said, so how about we can just, we're not going to package it for a long time. Go to your pharmacy. What we're going to do is we'll just package it for the next 4 weeks. We'll give you 4 weeks of medication, and then what we're gonna do is we'll see how it goes. And I would say 85 to 90% never go back. Other side, pharmacies will usually not fill 4 weeks, they'll usually fill 2 weeks at a time, is because that's how we get paid. So we're not trying to scam patients, and the other reason we don't want to give 4 weeks is because Mr. Smith changes his meds every 2 days, and I don't want to have to keep repackaging them. But you really have to let them know, you've got to spin it in a way that it's good for them. And it's a great service. And the only other aspect from a physician standpoint you gotta be careful is, you will see massive drops in blood pressure. Because the best one I ever had is I had a gentleman who was 60 years old when I used to work at downtown, and got his med every day, 90 days. Came in about a little while after, had a heart attack. And when the wife came in about 2 days after the heart attack, came in with bags of meds. And what it was is he was getting them refilled because his wife knew they were due every 90 days, but he never took them. So he just stored them and she found out he had batteries. So what we think our patients are doing is not reality. So like when you do go to compliance packaging, you can really and then if you are a physician, bring them in. I want to see your packs. And you'll be shocked at the amount of missed doses or other things. Or like I say, they'll have 2 weeks and they'll already be done a week, like all of them after a week. My favorite is it's like trick-or-treating. Oh, I like the pink ones, I want the blue ones, but I don't want these. And not only that, you'll get a lot of sense of what your patients are doing. And this is not just for physicians, for anybody. You'll know what meds they don't like, because it's a real good discussion point. Like they'll come in and you're like, why do you never take your morning meds? And it's really a lot of times like, I don't take the morning meds because I want to sleep in. You're like, we could just move them to lunch. Oh, we can do that? Yeah. But they don't bring it up because they think it's just silly, so stuff like that. A lot of little things. It's really, pharmacy ain't difficult, folks. Just count by fives. That's why as pharmacists don't like to get married, because tables never are seated in fives, they're seated by eights. So you're like, ooh. Yes, young lady. We're seeing more people. Yeah, she's asking. Yeah, asking, are we seeing a shift in how we're seeing patients now with the expanded scope of practices? We are. It never made, the worst part I used to hate is I'd be out in the store on a Saturday, a young lady comes in, has all the symptoms of a UTI. I know it's a UTI, you know it's a UTI, and I look at her and go, you have a UTI. And then I have to send her away, and then she goes to a walk-in clinic, and it takes 4 hours, and then they come back, and it's exactly the thing I was going to give you 10 minutes ago. So that kind of removes it. And like I say, with COVID, it's really changed the scope. People have changed how they see us. If you guys haven't, flu season is out right now. COVID shots are out right now. I'm not getting into it if you don't like COVID. Sorry, that's fine. There's shots available if you like it. Most of you, I don't know what your philosophy is, but you're going to be the vector of getting other people sick. So don't do it for you. Do it for the people that you potentially could get ill. If you like it or not, that's fine. Don't follow grandma's advice. Don't cough on people and wash your hands. That helps. Any other questions? I'm going to keep talking about other random topics. Lions. Yes, Ms. Lee, prize winner. What'd you get, by the way?
The box.
The box? Awesome.
So, I do want to hear from you about your opinions on CBD and the use of CBD with patients who have brain injury. Because there are patients who a lot of times come in and talk about CBD as if it's the holy grail of the new kind of medication.
The problem, so I sit on the OPA board and we had a really long fight with the government. My own person, I have no issue with CBD. I'm glad that we're doing it now. There's a couple issues with it. One, it was probably the most restricted medication before it became legalized. You could do a study on heroin easier than you could have do studies on cannabis before the laws changed. The problem is when my original report was what I would have liked to see is whatever cutoff it is, 10%. Anything below 10%, do recreational, have fun, I don't really care. Anything above that, this is not, I don't know how many other people, this is not our this is not our marijuana we grew up with. The marijuana we grew up with was probably like 4%, the really crazy stuff is 7%. We're talking 20, 25. These guys are purifying into oils. It is off the chart. And on top of it, you have a plethora of plants, plant strains, combinations. So, someone's saying I'm getting a 20% CBD. Well, what does that mean? This plant's combination, it could be 10,000 different components in the actual oils. Now, on a side note, I've seen, as you would say clinically, I've seen life-altering effects. I've seen patients that could not walk, could not survive, and doing great. I've had people with headaches. When you hit it right, it's great. So my best advice. The other thing too is patients are really afraid. So CBD basically the cannabinoids, compounds, and then THC is the stuff that gets you high. The fact of the matter is a lot of times you need combinations of both. You don't want a high enough THC content that, grandma's loopy, unless that would be fun. She likes cartoons again. But there is a lot of times you need like 1% to 2% because it will seem to accentuate what the CBD does. So don't have patients that are really fearful saying, I just want CBD, I don't want THC. Those that just want THC are just doing it for fun. So there is a combination, but it is really, it's the other part I don't like is the volumes they sell them in, they're in larger vials. I don't like the smoking component, obviously it's not good, so I prefer either edibles or the oils. Oils taste horrible, they're really horrific, and you have to buy larger volumes. I really wish there'd be a distributor that would come up with like 1 ml. Like here's 5 different 1 ml vials, try it. To see, because it can be expensive, so it's like, it could be several $100s. And a lot of, I was telling somebody else, the other issue when they went all recreational, all third parties, 95% of third parties just washed their hands of it and said, I'm not paying for it. This is like, I'm not gonna, like I wouldn't pay for chips, I'm not paying for your CBD, even though there's a medical reason for it. And there is more studies coming out, but like I said, it's so broad that we don't really, I couldn't tell you have to do Sativa 5 milligrams this many times a day. It really is a trial and error. And then let's throw out even more fun. Grandma goes to the local CBD store and she sees the person, and what I really like is they call them dispensaries, which just, yay, makes me feel so good. So then they said that they think, well, I went to Tim. Tim has a dispensary, and this is a dispensary, so this guy is basically the pot pharmacist. And it's Chuck, who just really likes to smoke blunts. And he's telling Grandma, well, that's what you should do, and some purple kush for Friday, don't get me wrong, there's some very good ones, but you have to be really specific. There's no single dispensaries in Essex County that have set off whistles, and no one's made an affiliation with like medical practitioners, which would be great to see. There are some pharmacies actually in Ottawa that are starting to do that. I really don't want to smell like pot all day, and I'm already fat enough. You know how fat I'd be if I worked in a marijuana dispensary? I'd eat those berries like crazy. Give me another one. I gotta actually time myself up. Any other questions? No other questions? I'm that riveting. I know, I'm so fascinating, right? I look good in this suit. Nothing? Yes? That's the biggest thing. Yeah, it's the funding, which is the big, and that's the other part. So the biggest question I'll get is, you as a physician will write a particular prescription, and the very first thing is the customer or the patient will come to me and say, here, and I'll do it, and I'll be like, it's not covered. And then the patient will say, well, why would the doctor write this then? And I said, because the doctor doesn't know what's covered, because this is the right drug. There is a lot of programs. One of the biggest ones that's missed is, I don't know if you guys all know about the Trillium program, Ontario Trillium program. That is eligible for every single person in Ontario. It doesn't matter if you make $100,000, it doesn't make if you make $10. It basically gives you coverage for every medication that's covered under the ODB Seniors program. I'm going to give you a couple other advice. If you have any of your patients go, it's really simple now. They've actually just moved to an online system, so you don't, because you'd send in papers and they'd lose them 8 times, and then you'd send them again. And now it's all online, so I'm sure they'll find a new way of losing online information, but until then, it's supposed to be better. It's based on basically, basically rough estimate, 4% of whatever you make. So if you made $100,000 a year, your deductible for you is $4 grand. And the reason I tell people, anyone who doesn't have coverage should apply for it, even if you never hit your deductible. So what happens is I can get into semantics. They break your deductible into 4 payments throughout the year. So when they do the calculations for your taxes, if you owe $400 a year, the first 3 months, their year starts in August, because I don't know why, but the government thinks that's a great idea. So if you came in August 1st, you would pay your first $100 of meds. After $100 of meds, everything's covered. You'll pay $2. And the next month, it starts over again. So I tell patients, even if you're not covered, especially with some of the talks today with these monoclonal antibodies, we're talking thousands of dollars. So I would tell patients it's going to take you an hour or two to fill out the form. Worst case scenario is if you never get the deductible, you don't. At least you can tell your patient, I know for a fact you'll spend no more than $400 on medications this year. And you can actually still have it even if you have other coverage. So it's a good program, but it's something good to go on. It's simple. The other issue is physicians are going to hate me when I say this. They do get lots of samples. They love asking their drug reps for samples for meds to give out to patients because it's the most fun thing ever. But you can get a lot of things like that. There are a lot of programs out there to help subsidize. If you just find out what the meds are, to call the company and say, I'm not paying for it. You're dealing with the patients that had a major traumatic, life-changing experience, and then what we should do now is throw more hurdles in front of them so they don't get the medications they need or deserve. So that's idiotic, and I don't know, I wish we could fix it, but so I'm running for governor. We are, the pharmacare program is supposedly getting pushed forward. We don't know how it's going to happen. Ontario's really a stickler on it. They're kind of looking for potentially a universal program. So right now, if you're in the province of Ontario, anyone from 0 to 25 years is covered, and anyone from 65 and above is covered. So as long as you don't need meds from 25 to 65, we're good. And so the program that Ontario is trying to pitch is a stopgap, saying I have coverage, so therefore my coverage will cover what it does. Whatever it doesn't, the government will then pay. Kind of idea. The government really wants everything across the board, which makes no sense. But let's not get into that. This is really spinning off the wheels, I know. Yes, how are you, by the way? You've been such a great person all day today. You really have, I'm serious. Okay, sir, go ahead. Great. I don't want to talk to you. She's very red. Matches her gray hair. It's okay, go ahead. This is the stand-up thing. This is called crowd work. So I'd normally say, hi, what's your name? She'd see like, Sue. And I'd be like, what do you do, Sue? And she's like, oh, I'm a dietitian. And I'm like, well, that's exciting. Go ahead. Don't cry. I'm used to women laughing at me. Don't worry about it. Go ahead.
How do compounding pharmacies work? Is there a regulation for
No, it's a big sign. So compounding pharmacies, and you will get this. There's probably 4 left in Essex County, or maybe 5. What it was is so for the last 20 years, if you had diaper rash, I could mix hydrocortisone cream and Canestin for diaper rash. I've done it forever. Pharmacists were made that way. And then years ago, and I know you're going to find this hard to believe, a bunch of people at a college sat down and said, you know what we should do? Let's make this way more difficult. So they implemented, for a pharmacy to be a compounding pharmacy, it's approximately $150,000 to $200,000 on equipment you have to spend just to have the rights to do it, and you have to have bunny costumes and big orange glasses and I don't know what else. So what's happened is most pharmacies have stopped compounding. So if you have a particular compounded program, they're very limited. In Windsor, there's Hunter's, there's Banwell Pharmacy, there's one in Leamington, and I think there's another one up on near Walker Road, near the Costco, and that there's another pharmacy there. But other than that, most pharmacies stepped away. There's so much hassle of it, so much paperwork, they don't. You can do emergency compounding, like one-offs, but mostly, and the problem with compounding is a lot of the times they're not covered. Oh, I think there's also one on Ottawa Street, or not Ottawa Street, Olette. So they're hard to find, you just gotta find the pharmacy, and you're probably looking at 48 hours to get it. And the cost can be astronomical. And your insurance may cover it, but probably not. Well, if you really need it, it won't be covered.
Yeah.
If you do, then you're fine. It's frustrating. Someone's fixing your hair. Question, or just want to fix your hair? Just fixing your hair, okay. You're showing off your hair, thanks. Follicularly challenged over here. I know I'm just running, so we should just put in the date, where the line tickets. We're good? I think we're good at the end of the day? Okay. Thank you, guys. I apologize, I'm really so prepared, but that's okay. So we have two lovely